So, good evening. Today's topic is on restorative materials in pediatric dentistry. Okay, so I'm Dr. Anshad. I'll be taking this lecture for you guys. Okay, so before going to the lecture, if at all I'm not audible or if you have any doubts, please type it in the chat box. Okay, so basically today we'll be dealing with the most commonly used restorative materials in pediatric dentistry. Okay, so as we know in pediatric dentistry, the most commonly used materials are glass enamel cements, composite resins, or sometimes we have now the recent advances where there is a combination of these two materials. Okay, and you should know that silver amalgam is less commonly used. Okay, due to its obvious side effects, like there is mercury toxicity. Okay, and it requires a very ardent preparation. It actually requires an extensive preparation which might not be always possible in your primary treatment. Okay, and coming to glass ionomers, it will be considered. Yeah, do you have a doubt? Okay, so coming to glass ionomers, it may be considered. Yeah, sorry guys. Can you hear me? Hello? Hello? Guys, can you hear me? Yeah, okay, sorry. Okay, fine. Okay, coming to glass ionomers, it may be considered therapeutic because they release fluoride over time and also cause minimal shrinkage during cell setting. Okay, and even composite resins, they possess durability and superior aesthetic qualities. Whereas these might not be the case for silver amalgam because we know it doesn't have fluoride release, which is one of the most important factors when we take into consideration the restorative materials for pediatric dentistry. Okay, but again, it has its own what to say advantages, like it has very good strength, which might not be always the case for glass ionomer cements. Okay. Now, coming to the list of restorative materials which are used in pediatric dentistry, we know we have liners and bases. Okay, we use different liners and bases: glass ionomer cement, composite resin, zinc oxide regional cement, calcium hydroxide, stainless steel crowns, and strip crowns. Okay, when and where we use all these materials, we will discuss it individually. Okay, coming to liners and base. So I'm sure that you guys must be knowing what a liner and a base is. Can anybody tell me? It is in the slide. Can anybody tell me what is the difference between these two? It's there in the like it's there in the slide. Okay, what is the difference between a liner and a base? Anyone? Nobody. Are you guys there? What is the difference between a liner and base? Okay. Okay. So I'll just tell you. So basically, these two materials, no, we use a liner for pulp protection. Basically, it is used for protecting the pulp. Whenever there is a thin layer of remaining dentin, okay, we will actually put a liner, okay, for initiating the formation of reparative dentin. Okay, that is what a liner is used for, and it is basically for protecting the pulp. Okay, apart from that, it also has other functions like sealing of the dentinal tubules, etc. So it is thinner, as you can see. I have highlighted it in yellow. It is a thinner material. Okay, it doesn't have much of strength. So basically, one classic example of liner would be your calcium hydroxide cement. Okay, or you can say a cavity varnish, which is usually applied before placing an amalgam restoration to prevent the marginal leakage. Okay, so all these things are classic example of a liner. Whereas a base also, it also does a similar function. Okay, you can say it also does kind of a pulpal protection, but on top of that, it also does thermal insulation as well. So it will protect the pulp from thermal changes due to heat and cold. And we know these thermal changes are one of the major causes for damage to the pulp. So it actually protects the pulp from thermal changes also. So it provides, apart from your pulp protection, it gives thermal insulation as well. with due from thermal like forces as well as the masticatory force. So you as the name suggests, it will actually be given like a thicker layer. Okay, so always keep in mind base is thicker and cavity liner is thinner. Okay, and examples of materials which are used as bases: zinc phosphate cement, zinc polycarboxylate cement, glass ionomer cement, etc. Any doubts? Understood, guys? So basically, base is thicker and it is used for thermal insulation apart from pulpal protection, whereas cavity liner, it is a thinner layer which is used for pulpal protection, and it will actually initiate the formation of reparative dentin. Okay, understood? Please respond. Okay, if you understand, please at least type it in the chat box. It's on. Okay. Okay. Now coming to the first material, which is glass ionomer cement, very important in pediatric dentistry aspect. Okay, it was introduced by Wilson and Kent in 1969. Okay, okay, guys. Yeah, it was introduced in 1969 by Wilson and Kent, and the major like what do you say? The classification. There are other types of glass ionomer cement also now. Around 9 types are available, but the broad classification, at least you guys must be knowing, that is type 1 is luting GIC. Basically, it is used to cement the indirect restorations like your crowns, your bridges, etc. And it is also used to even cement the molar bands for orthodontic purpose. At least some of you must be undergoing orthodontic treatment, so you will be knowing what a molar band is, right? Which has molar tube and in which the wire will be attached. So you will be learning about these things when you come to the clinics, and you'll understand it much better. But just keep in mind, type 1 luting JC is for actually cementation. Okay. It can be for crowns, bridges, molar bands, etc. Okay. Type 2 is for restorative purpose. In general, for all the restorations, we use type 2 restorative GIC. Okay. And type 3, as I told, as a base and liner. Okay, it can be used as a base or a liner based on the thickness of the material. Okay, so these are the three functions or the broader classification of your glass ionomer cement. And as I told you, right now there are around 9 different types which are available, but at least you guys must be knowing, and we'll be discussing, it is coming I think in the further slides, different types, but at least you should be knowing this broad classification: type 1, type 2, type 3. Okay, for your exam point of view. Now coming to modifications. So in recent year we have like as the days are passing by, there are modifications done to this material. Okay, because it's a time tested material, because it has been shown to be very biocompatible. Ease of manipulation is there. It has shown fluoride release and stuffs like that. So due to these things, this material is being modified to overcome its drawback. So and also for the ease of the operator. Okay, some I'll tell you what these things are. So first thing is what first modification is water based GIC. So water based GIC, basically you should know that the cement usually is a polyacrylic acid. GIC, it's a polyacrylic acid, and it is in copolymer with itaconic acid, tartaric acid, malic acid. I'm sure you must have learned this thing in your operative dentistry class, but that is the acid. And the powder is usually your calcium aluminum fluorosilicate glass. Okay, so and it is an acid based reaction when this powder is actually mixed with the acid. Okay, so I'll come to the reaction, but here in water based GIC, instead of this polyacrylic acid, we will be using water as a liquid. Okay, and this polyacrylic acid will be already incorporated in the powder in a freeze dried form. Okay, that is called as water based GIC. Understood? So acid is already there along with the calcium aluminum fluorosilicate glass, and but the acid is in a freeze dried form and it is incorporated into the powder, or we can say it is part of the powder, and water is just the medium to get the what do you say, the mix, the acid base reaction to get started. Water is just the medium for it. Okay, so that is a type of modification. Okay, so basically what happens is sometimes this liquid gets evaporated, okay, very fast, and gets lost very fast, and the properties are damaged. So in order to protect these things, we they have actually made this polyacrylic acid into a freeze dried form. Okay, Next one is resin modified GIC. As you know, GIC has very good properties, but sometimes it has the main drawback is it doesn't have the strength compared to that of a resin like a composite. Okay, so this like along with the glass ionomer cement, okay, this resin is also incorporated. So we have now resin modified GIC, and which is very commonly used. Even in our clinics, we use resin modified GIC so that we get the properties of both the composite as well as GIC in one shot. Okay, so that is another modification. Now coming to a method of activation, you can actually activate. See, resin modified GIC, basically it's a resin and it gets activated by light. Okay, we all know how it is because it's a resin and it gets polymerized. So this light activated GIC is a modification, and the most conventional form is the chemically activated GIC, which we actually mix manually. Okay, we mix the powder and the liquid together, and that is the chemically activated GIC, and we have even setting by light activation. So light activation, don't confuse yourself. This is to activate the resin part of the resin modified GIC. Okay, understood. So the advantages, as you know, composite, no, sometimes it undergoes what is called as polymerization shrinkage, which is said to be one of the disadvantages of composite. So in this part, what happens is this Raid has typed something. I didn't understand. What is it, Raid? Can you type it in English? You have typed some doubts. I didn't understand. Do you want me to repeat? Oh, my. Can you hear me? Okay, one second, one second, one second, one second. Hello? Can you hear me now? Guys, can you hear me? Is it clear? Okay, okay, fine. Okay. Yeah. So, what was I? Yeah. With regard to what, Bashar? I didn't get you. One second, one second. I don't know what is wrong. 1 second. Yeah, it's maximum volume. Okay, just let me know, okay, if my voice is clear. Okay, so coming to light activated GIC, this light activation, we use this light to actually activate the resin part of the resin modified GIC. Okay, what happens is this resin, no, it gets polymerized, and this, if at all any polymerization shrinkage happens, that will be actually taken up by this unactivated glass ionomer part. Okay, so as a result, there is less internal stress. That is one advantage of light activated resin modified GIC. Okay, then we have the conventional chemically activated GIC, which we will mix manually using powder and liquid. Okay, that's how we actually activate it. Then we have something called as colored GIC, especially for pedo patient. We have one company called as Voco. Okay, I'll just type it in the chat box. They actually have released this colored GIC for pediatric patient, like pink, green, purple, and all. So they have added colored additives, and we'll tell the children that okay, we are coloring your tooth, we are coloring it pink and all, to make them more conducive to the dental treatments, because one of the major challenges of pediatric dentistry is the cooperation of the patient. So these are different techniques in which we use. Like we'll tell that okay, like we'll color your tooth green or pink or something like that, and so that is also a modification of GIC. Why we are sticking to GIC? Because of mainly because of its fluoride release and ease of manipulation. Okay. So as I told you, there are apart from the three functions, like the it can be used as the luting cement, restorative cement, okay, liners and bases, etc. We have other uses of GIC. Okay, like it can be used as a pit and fissure sealant. Okay, pit and fissure sealant is a preventive procedure which we do in deep pits and fissures of a sound tooth. There is no caries, but we are actually trying to prevent the caries. If at all we find that the pit and fissure of the tooth, the naturally occurring pit and fissure of the tooth can actually lodge food debris and may lead to future dental caries, we will actually seal it off with a pit and fissure sealant material. Usually it is a resin, but we can use GIC also as a pit and fissure sealant material. as an orthodontic cement. I already told you, for orthodontic purpose, like for bonding of the bracket, or for actually the cementing the molar bands, all those things, we can use the JC as an orthodontic cement. For core buildup, means when there is a poor crown structure, we are actually trying to build up the crown structure as a core buildup material. So these are the various functions of, and this is usually done during the root canal procedure. So these are the various other functions of GIC. Okay. Now coming to the advantages of GIC, as I told you, it has chemical addition to the tooth structure. So there is direct bonding to the tooth structure, whereas your amalgam doesn't have that. As a result, it can cause future problems like delayed expansion and stuff like that. Okay, aesthetic is good because it is a tooth colored material. Again, compared to amalgam, it will be in silver in color. Okay, and anti-cariogenicity because of the fluoride release. Coming to disadvantage, it has low fracture resistance and water sensitivity. Okay, because the strength is not very great, it gets fractured very easily, and it is water sensitive material. This is an important aspect. I'll touch upon it. Okay, I'll tell you what it is. Okay, let me go to the next slide. While explaining the mechanism of action or how it is being set, I'll actually setting reaction. I'll just tell you what it is. Okay, so coming to the contents of GAC, as I told you before, powder contains calcium fluoroaluminosilicate glass. So these are the various cations which are actually present in GIC, and the liquid is consisting of polyacrylic acid or polycarboxylic acid in copolymer with itaconic acid, maleic acid, and tartaric acid. Okay. So coming to the manipulation of GIC, it is actually dispensed into a paper pad and divided into two equal parts. So we will actually put the powder and we will actually separate it into two equal parts, and we'll put one or two drops of liquids like polyacrylic acid into the paper pad, and we'll mix using an agate spatula. Okay, so we mixing usually happens within anywhere between 40 to 45 seconds. Okay, so that was when we were dental students. When I was a dental student, I used to do it like that. But nowadays, you have what do you say, automated mixing of JAC. Like it is very easy for you guys. Okay, and we have a practical. The first practical will be on no, not the first practical. I think the second or third practical will be on how to actually manipulate JAC using this machine. Okay, so we have the auto mixer which is available, and we have the what do you say, GAC capsule. Okay, so don't worry regarding this thing. It will be demonstrated in your practical lab. Okay, how to do it, and all the students are expected to actually manipulate it like this. Okay, so if I tell it, you won't understand it. Basically, it is very easy. We have a, what do you say, GAC activating gun in which we'll be placing the capsule. Okay, and we will actually try to activate it using an activator for 5 to 10 seconds based on the instruction of the different companies have different instruction of mixing. Okay, some say 5 seconds, some say 10 seconds. Okay, and it'll will show you how to do this, so don't worry. So this is very easy now for you guys. It is now very easy. Okay, and finally yeah, and after application, before application, what you do is you actually condition the cavity with 10% polyacrylic acid and wash it after 10 seconds and dry it rightly, because conditioning of the cavity is something have you guys heard of smear layer? Guys, have you heard of smear layer? We have something called a smear layer, right? Yeah. So actually, to remove the smear layer, no, we actually condition the cavity. We have to condition the cavity to remove the smear layer. So basically, smear layer is actually the debris. Okay, the organic and the inorganic debris, which is actually found on the tooth after your cavity preparation or after doing some kind of manipulation. It is said to have like the collagen debris, and the that is which will be your organic part, and the inorganic part is usually your glycosaminoglycans. No need to go into the details, and it is said to even have like bacteria also. Okay, so the presence of smear layer will actually interfere with the proper bonding of the GIC with the tooth structure. That is one thing. Then there is chance of formation of secondary caries and stuff like that. So it is always best that we actually, and it is mandatory that we remove the smear layer. So to remove the smear layer, what we do is we condition the cavity with the same liquid which is used for GIC. That is your 10% polyacrylic acid. So if we have the normal powder and liquid GIC, then we can use the liquid to actually, same liquid to actually use the to use it as a conditioner. But right now with capsule, no, inside the capsule only we have what do you say, the powder as well as the liquid. Okay, so we don't have this liquid available outside. So what they provide, these companies which are actually providing with this capsule, capsule GAC, they give a separate bottle of this polyacrylic acid to be used as a conditioner. Okay, and I think like when we give demonstration, we'll show you that. Okay, so and once like the condition is done, then we'll place the GAC after activation. And once GAC is what do you say placed, then we can give a protective covering. If it is a self cure GIC, then what we do is we can give a protective covering like a petroleum jelly or a fluoride varnish. Okay, so why we do this, I'll just explain. Okay, for that you should know what is the setting reaction of GIC. So usually the setting reaction of GIC, how it happens is like when the aqueous part, that is the polycarboxylic acid or the polyacrylic acid, when it is actually mixed with the glass particles, okay, the glass particles which are like as I told you, calcium, aluminum, fluorosilicate glass, which is actually rich in calcium, strontium, aluminum, etc., silica. It's actually mixed, and the acid-base reaction will happen. Okay, so when it is happening, the powder and liquid actually what do you say, combine, and the cations from these glass, that is the calcium, strontium, and fluoride, and all these things, will start leaching into the aqueous, like what do you say, acidic component, that is your polyacrylic acid. Okay, so once they actually leach, then the polyacrylate cross-link polyacrylate chains are formed. Okay, this is a little bit difficult to understand. Just remember, when the glass particles combine with this acid, polyacrylate matrix is formed. Okay, and as this reaction progress, this matrix will get hardened. That's how the GIC is actually setting. Okay, and in the center of the matrix you will have cations, especially mainly aluminum will be there. And this process, this is the initial set which is happening, and this initial set is what we are seeing clinically. Okay, it will take place within 2 to 10 minutes, within anywhere between 2 to 10 minutes. This is where this clinical, the initial set is happening. And the final set happens over a period of 24 hours. Okay, so you should not think that, okay, 2 to 10 minutes, the set is over. No, the final set usually happens anywhere between, 24 hours. So during this initial phase, water is very important. So when coming to the properties of GIC, water absorption or water solubility water balance is one of the important properties of GIC. So you should know that during this reaction, there is inherent water which is mawjood in this GIC. Okay, so this water is very important for the initial set to happen. So during this initial phase, if at all, before this 2 to 10 minutes, if at all the GIC is coming in contact with the saliva or the air, this saliva can wash off this matrix forming ions. Air can actually cause the condensation of this mobile water, labile water, which is mawjood. Okay, so to prevent these two things, okay, to prevent the washing away of matrix forming ions with saliva, and to prevent the evaporation of this like the labile water, we apply a petroleum coating, like a petroleum jelly or a fluoride varnish. Okay, that's why. So you should always know that this is for protection and for proper initial setting to happen. Okay, understood, guys? Do you want me to repeat it? Did you understand? That's why we give a like a protective coating, like a fluoride varnish or a petroleum jelly. If it is light activated, no need for this. Okay, I'm talking about this is if it is chemically activated or self cure. Okay, understood? Do you want me to repeat this? Ibrahim, do you want me to repeat this, or you typed yes? You understood? Okay, okay, clear. Okay, fine. So, oh no, it's not clear. Okay, fine. Okay, I'll just repeat it once more. So basically, you should know that the GIC setting is an acid-base reaction. It's an acid-base reaction. Acid is your polyacrylic acid or your polycarboxylic acid, and your like the powder is your this thing, calcium fluoroaluminosilicate glass. Okay, it's actually cations, okay, of calcium, fluoride, aluminum, silica, etc. So when these two are actually being mixed, this cations of calcium, aluminum, fluoride, silica, strontium, and everything will actually leach into this acid aqueous phase. That is your polyacrylic acid, it will leach into this, cations will leach into this acid and form polyacrylate chain matrix. Okay. And the center of the matrix, this matrix in the center, the cations will start leaching and make it harder, like aluminum and all will go and occupy the center of this matrix. So this matrix forming ions are very important for the initial set. Okay, so initial set takes place within 2 to 10 minutes, which you will be seeing clinically. You will think that, okay, the GIC is set. The final set takes place anywhere between 24 hours. Okay, so once the initial set happens and we are protecting the initial set, then the final set will automatically happen, provided you are not chewing anything hard or anything. You are like as they say that once you place a GIC, you are not supposed to chew anything hard or sticky for 24 hours, right? So the final set will happen in its place. So during this phase, the water is very important. Okay, there will be labile water which will actually help in this process, and this labile water should not be very excess or very less also. Okay, so this water will help in the initial set, and to protect this labile water from actually getting evaporated, and to prevent the matrix forming ions from being washed away with saliva, we actually provide a protective coating like a petroleum jelly of Vaseline or a fluoride varnish. Okay, so that's why we actually put this Vaseline or protective covering. I think I answered your question. Okay, so this is the powder. I think it's clear, right, Ibrahim? Now is it clear? Tell me fast. Tell me fast. Is it clear, Ibrahim? Okay. So I already spoke about this acid-base reaction. There will be formation of polyacrylate chains during initial setting, which are strong and insoluble in water. Calcium and aluminum ions will cross-link as the reaction progresses and form a rather porous network. So these are the properties of GIC. It has ion release and karyostatic. Okay, fluoride ion release is one of the major advantages of GIC, especially in pedo. Water balance, I already spoke regarding the importance of water in the setting reaction. It shouldn't be too high or too low. Okay, water is very important, and it is part of the set cement, initial set cement. Okay, and this will determine the success of your final restoration. Okay, it is biocompatible. Okay, it doesn't cause any adverse reaction to the body, not like your amalgam, which can cause mercury toxicity. It is much more aesthetic because it's a tooth colored material. The mean survival time of a GIC restoration is 12 months. Okay, so it is said that you might have to replace GIC restoration every 1 year or 2 years. Okay, if you give very good, then at least every 1-2 years you will have to actually review the patient. Okay, and recent advantages of GIC, there is something called as viscous glass ionomer cement, which is actually which is a condensable GIC, which was actually introduced to replace amalgam, especially for your class 2 restorations and all. Here they have more of your cations like your calcium, phosphate, strontium, etc. Okay, and but studies have shown that it is not as effective as amalgam when we compare the longevity of the restoration. Okay, because amalgam is still the best material. If at all it is given very good, if you place amalgam better, then it will stay for a longer period of time, because it's the best material when we talk about the strength of the material. Okay, so that's why there was another innovation called a cermet cement, in which the silver particles were actually incorporated with glass ionomer cement, and cermet cement is said to have both the properties of GIC as well as silver, because of its what do you say, incorporation of silver particles. It is said to have more strength also than your conventional GIC. Okay. So now coming to resin modified glass ionomer. So as I told you, there another modification is actually incorporating resin, so that we get the advantages of resin material as well as your glass ionomer cement. So here it's a mixture of glass and an organic acid and resin polymer that actually hardens when it is light cured. And here you have to keep in mind that light curing only activates the resin, not the inactivated GIC. Okay, that's very important. Now coming to interim therapeutic restorations. Okay, so something like ITR, it is actually usually done on tooth, which is actually partially erupted. Okay, sometimes you will see a 6 which is actually only one aspect, one mesial side of the 6 is erupted, distal is still erupting. But in the mesial side of the 6, there is already caries. Okay, but you cannot wait for the tooth to completely erupt. So you will do something called as an interim therapeutic restoration. You will just do a restoration for the time being. Okay, as like an interim phase, you will be doing the restoration. Okay, and usually it is done on molars. Okay, molars only face this issue. Okay, so it is basically removing carious tissues using hand instrument only. So don't confuse this with ART. ART is also using ART is a traumatic restorative treatment. It is also using just hand instrument. Don't confuse interim therapeutic restorations with your ART. Okay, so ITR or interim therapeutic restoration is less traumatic. There is no need of electricity because you are using only a hand instrument. You conserve the tooth structure and it is of low cost. Okay, so usually, if at all, you will be just excavating the caries on the side which is partially erupted, and you will be placing a GIC. And GIC is again resin modified GIC, or GIC is the material of choice to be used as ITR because of its fluoride release. Okay. So as I told you, ART, it's not like an alternative restorative technique. It is a traumatic restorative technique. Everybody keeps it's not an alternation for normal treatment. It is a traumatic restorative treatment, and don't confuse ART with interim therapeutic restoration. Okay, because ART is done on tooth which is fully erupted. Also, it is usually done without the help of electric driven instrument. Only hand instruments are used, like a spoon excavator, enamel hatchet, etc. And you will be having a separate lecture on ART where we'll be discussing regarding ART. Okay, so don't worry. Okay, and again, for ART and interim therapeutic restoration, you should know GIC is the material of choice. Now coming to composite resin. So before going, any slide you want me to repeat fast, please, because we are already taken up a lot of time. I have still more slides. Tell me fast if you have any doubts in GIC. Okay. No doubts. Perfect. So now coming to composite. Composite is also one material which we are actually using in pediatric dentistry. And you know, like broadly, based on the filler particles, which is actually giving the strength to the composite, we have divided it into type 1, type 2, type 3. So type 1 macrofilled composite resin, because the filler particle size is very big, somewhere between 5 micrometer to 25 micrometer. You have the macrofilled composite resin. Okay, and it is the drawback of this is less aesthetics and less polishable surface. Okay, because it is used in area which can actually withstand masticatory force. As the filler particle size increases, the polishability and the aesthetics, everything actually will diminish, right? So rough surface is created. So this is basically used in area which can actually withstand lot of forces. So you are looking at class 1 cavities of your occlusal caries and all those things of your molars, where you want more force, materials which can actually withstand more force. Okay, so type 1 macrofill, higher filler particle size and used in posterior areas, and the disadvantages is aesthetics and less polishable surface. Okay, rough surface is created. Microfilled, whereas the filler particle size is very less. Okay, 0.01 to 0.04 micron meter is the filler particle size. It is used in areas where aesthetic is of concern. So for anterior tooth restorations and all, you use microfilled composite resin. And again, the drawback is because of the less filler particle size, the strength is compromised. Okay, so as a result, hybrid composite resin having the property of both was introduced. Nowadays we have even nano filled composite resins and stuff like that. So we can use composite, the hybrid can be used both in anterior as well as posterior. Okay, microfilled basically in your anterior where aesthetics or any aesthetics, like any restoration where aesthetics of concern, and macrofilled we use in areas where we want tooth to withstand, restoration to withstand more occlusal forces or masticatory forces. Okay. So this is a composite kit. It comes with an etchant, a bonding agent, all those things. I think you already know regarding this thing. Okay, you know how what the steps. I think I have a slide. Yeah, it is there. It is there. So we'll just discuss. Now coming to the modifications or variations in composite resin, we have flowable composite with, again, which has more flow property, which can be used even like in areas where there is pit and fissure caries. Okay, in which we don't want too much of tooth preparations and stuff like that. Then packable composite, you can actually, so usually when we do composite filling, no, we do it in increments. In pedo, what happens is the patient wants it, won't allow you to do it in increments because they will be usually restless. Okay, so you will have to be very quick when you are, and if it is a big cavity, you won't have the time to like the luxury to do incremental filling. So the packable and incremental filling is said so that the curing happens happens properly. That's why we do incremental filling and we do curing, then we again place another increment. So, but packable composite was introduced so that you can put, even if it's a big cavity, you can put a larger like a volume of material and cure it. Like you can pack it with the full the cavity fully with the composite material and cure it, and the curing will reach till the depth of the material. Okay, so that is another one very good innovation in pediatric dentistry, like packable composites. Then based on the activation, if it can be self cured or chemically activated system and visible light activated system, both are available, and dual cure. And there are composites which can be self cure as well as light activated. Okay, so these are the variations in composite resins which are available. Coming to manipulation, before actually placing the material and all, we do acid etching. Okay, for permanent, and it is usually 37% orthophosphoric acid which is used as an etchant. Okay, to cause demineralization so that the resin tag is formed. So usually for permanent tooth it is up to 20 seconds, and for primary tooth also it's up to 20 seconds. Before there was a school of thought that for primary tooth you will have to etch for a longer period of time because of aprismatic enamel structure. But now it is said that no need for that, and you can cure for the same amount of time for the permanent as well as the primary tooth. Okay, once you do the etching, then you apply the bonding agent, application of the bonding agent, and then followed by delivery and placement of the composite resin. And build has to be done in incremental layer for proper curing and polymerization to happen. But as I told you, we have materials like packable composites which are available now, in which you need not put it in increments. Okay, so once you finish the restoration, you can do finishing and polishing of the composite restorations, and we have disc like soft flex disc and composite, different types of composite polishing kit which is available for your final polishing and finishing. Okay, so that was with regard to composite. Any doubts in composite? Any doubts in composites? It is basically the same thing. Okay, only thing we are using it in pediatric patients. Okay. Coming to next material which is most commonly used, zinc oxide eugenol cement. Before going to the material, this thing, I'll like to tell that zinc oxide eugenol, the major application in pediatric dentistry is its use as an obturating material while doing pulpectomy procedure. Pulpectomy is similar to your root canal treatment in your permanent tooth. Only thing is, in your root canal treatment, you are putting inert material like gutta percha. You are putting an inert material like gutta percha, which is non-resorbable. Okay, which is like a material which doesn't undergo resorption. Whereas you want the primary tooth obturating material to undergo resorption, because the root gets resorbed, and it will be eventually replaced by the permanent tooth, right? So if you are putting an inert material like gutta percha in the primary tooth while obturating, the tooth will be resorbed, but the gutta percha will act as an artificial root, and it can actually cause damage to the permanent tooth, but it can cause deviation of the permanent tooth, but all such complications can happen. Okay, that's why we don't use an inert material like gutta percha when we are actually doing a pulpectomy procedure, which is nothing but your root canal treatment in a primary tooth. We actually don't use material like gutta percha. We use a resorbable paste. So zinc oxide eugenol is a resorbable paste obturating material which can be placed like as your final obturating material in your primary tooth, and it will also resorb along with the root of the primary tooth. Okay. So that is the primary application of zinc oxide eugenol in pediatric dentistry. Then it can be again used as a temporary restorative material, as a base, as I told you, as an insulating base, not a liner. As a base, it can be used as a root canal sealer. Okay, when you are actually using like in your permanent tooth, when you're obturating using gutta percha, you can use it as a root canal sealer to coat the gutta percha. You can use zinc oxide eugenol cement. And obturating material in your primary tooth, the most important use. Then as a periodontal dressing following your to facilitate the healing, like you can place zinc oxide eugenol pack after your flap surgery. Okay, when there is actually some kind of a pocket defect or periodontal defect. Okay, following your periodontal surgery, you can use zinc oxide eugenol cement as a periodontal dressing. Okay. So coming to the manipulation, powder liquid ratio of the manufacturer should be followed. So they say like different manufacturers say different powder liquid ratio. Some say 1:1, some say 2:1. So you have to follow the manufacturer's instruction according to the company. Use cool dry glass slab or mixing pad. Mix using a stainless steel spatula. Okay. Why? Because some cement, no, they give exothermic reaction. They give off heat while being when actually the mixing reaction takes place. No, the mixing reaction takes place. Heat heat is generated. Such reactions are called as exothermic reactions. So when heat is generated, no setting takes place very fast. So you will get very less working time. Okay, setting time is very fast and working time is less. So always use, instead of using a heated or glass slab, use a cool dry glass slab to actually compensate for this exothermic reaction. Now for zinc oxide, cement, and for calcium hydroxide, it is there, but it is not very significant, you can say. But the most important material which has this drawback is zinc phosphate. Okay, always keep this in mind. Zinc phosphate cement gives the maximum exothermic reaction. Now coming to the next material, okay, calcium hydroxide. Here again, it is used as a obturating material for endodontic purposes in primary tooth. Calcium hydroxide iodoform paste, metapex, okay, which is the primary obturating material for pulpectomy. Okay, keep this in mind. It is the major application in pedo. Okay, it is used calcium hydroxide along with iodoform paste, metapex. Okay, the combination is called as metapex, which is actually the major application in pedo. We use this along with zinc oxide as material for obturating primary tooth. Indication, again, it is used as a cavity liner, whereas zinc oxide was used as a base. I think remember the difference between liner and base, right? Liner means it is thin, okay, whereas base is thick, okay. So calcium hydroxide is used as a cavity liner, not as a base. Okay, keep this in mind. Then it can be used as an indirect pulp capping agent in your primary tooth as well as your permanent tooth. Okay, indirect pulp capping means there is thin layer of dentin which is remaining, and we want to actually initiate the formation of reparative dentin. Okay, so we place a medicament like calcium hydroxide. It can be used as an IPC agent for both primary as well as permanent tooth. Direct pulp capping agent in permanent tooth. Okay, so direct pulp capping as a agent, we use calcium hydroxide only in permanent tooth, not primary tooth. Very important, because see, in your primary tooth, it is said to actually initiate or cause internal root resorption, because studies have shown that there is odontoclastic proliferation. Okay, in primary tooth, when you actually direct pulp capping means the pulp is exposed and you are placing a medicament on top of it and sealing it off. Okay, and waiting for the healing to happen. So that is direct pulp capping. In direct pulp capping, there is a thin layer of dentin which is remaining. Whereas in your direct pulp capping, already the pulp is exposed. There is a pinpoint exposure. Okay, so it can be used as a direct pulp capping agent in permanent tooth. If at all there is a pinpoint exposure, a fresh exposure, you can use calcium hydroxide in permanent tooth, because it is said to cause odontoblastic proliferation. Blastic, okay, not clastic. Okay, odontoblastic formation. There is formation of reparative dentin. Whereas in your primary tooth, if you use it as direct pulp capping agent, it will cause internal resorption because there is odontoclastic proliferation. Hope you guys understand the difference. Okay, got it? Oh. Guys, did you understand? Please respond. Okay. 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 And other endodontic applications. Okay, as I told, it can be also used as a root canal sealer. Okay. Okay, guys, got it. Yeah. Okay. Now coming to powder liquid ratio of the manufacturer, like it again, according to the company or the brand, it should be followed. Like whatever is being instructed, that you have to follow, whether it is 1:1 or 2:1 or whatever. Okay, dispense only when needed. Okay, you should dispense it only when needed, because in my external environment it tends to set very fast. Use cool dry glass slab or mixing pad. Same like to prevent the exothermic reaction to actually interfere with the setting reaction. You have to actually use cool dry glass slab and mix rapidly using a stiff spatula. Okay, so that was with regard to calcium hydroxide cement. Now just comparing the GAC advantages of GAC with silver amalgam. As I told you, GAC is biocompatible, whereas silver amalgam will cause mercury toxicity. Aesthetics is good in GAC, whereas silver amalgam poor aesthetics. Anti-keratogenicity, there is fluoride release in GAC, whereas silver amalgam can cause marginal leakage. Okay, marginal leakage can happen due to, because it doesn't have chemical addition, whereas GAC has chemical addition to the tooth structure. Okay, whereas the amalgam doesn't have chemical addition, and that's where there is a chance of marginal leakage. GAC, it is easy in manipulation, whereas silver amalgam can cause delayed expansion. If at all there is some kind of moisture entrapment during amalgam trituration, then what will happen? It will actually within 1 to 7 days after placement of the GAC, there can be delayed expansion. It can expand after even setting. Okay, if there is moisture entrapment during trituration, and this will cause post-operative pain and other complications. Okay, so these are the disadvantages of GIC, sorry, amalgam when compared with disadvantages of amalgam when compared with GIC. Okay. Now coming to stainless steel crown, very important. We usually use it as in different I think do we have the scenario? Yeah, indication is there. Okay, so it is very when you come in your level 12, all of you are expected to actually place one stainless steel crown. Okay, so here you have to keep in mind it is very simple. We have preformed crowns which are already fabricated, and we have a kit of different size. Okay, so you need not actually send it to the lab for actually fabricating the crown. We have crowns of different size. So what you have to do is you have to measure the mesodistal dimension of the tooth in which you are planning to give a crown. The indications of stainless steel crown I'll tell, but one classic indication is following your endodontic treatment. You are doing a pulpectomy or pulpotomy in your primary tooth. You want to give a crown, just like in your permanent tooth after root canal treatment. You are giving a crown. You want to give a crown in your primary tooth following your pulpotomy or pulpectomy procedure. That is one classic example. So you will actually measure the mesodistal dimension of the tooth in which you did the pulp therapy. Then you will just do the occlusal reduction, 1 to 1.5 occlusal reduction, and you will do the proximal clearance. You won't touch the buccal and lingual side. Okay, very easy. Just the proximal clearance and occlusal reduction, and you will use a lutein cement like GIC and cemented. That's it. Okay. So before coming to anterior stainless steel crown, I'll just go to the indications of stainless steel crown. Indications of stainless steel crown is extensive decay in primary tooth. Okay, not necessarily pulp and involvement, but if at all there is a multi-surface caries. So rather than doing an MOD and restoring it with amalgam restoration, you will prefer giving a crown. It will make your job much easier. Proximal restorations and all, and both the surfaces are involved. Okay, so other than doing an MOD restoration, you will be actually giving a crown. That is best. Okay, following pulp therapy as a preventive restoration. If at all you are anticipating some kind of future caries and there is a proximal lesion, you can actually use it as a preventive restoration. In developmental defects and anomalies like enamel hypoplasia, okay, then amylogenesis imperfecta and all, when the MID, all these conditions, the quality of the enamel and dentin is affected. In situations where quality of enamel and dentin is affected, you can actually give a stainless steel crown. Okay, as an abutment for space maintainer or denture. So this is a little bit like abutment means usually, like for example, you are giving a band and loop space maintainer. Okay, so usually the banding is just Google and see band and loop. Okay, then you'll understand. I don't have a picture of band and loop. Then you'll understand band and loop space maintainer. Just Google and see. So usually, if at all the first primary molar is missing, you will ban the second primary molar. Okay, and the loop will be actually extending to the canine. Okay, so if at all the first primary molar is missing and second primary molar is decayed, grossly decayed, you can give a crown on the second primary molar and put a band on top of it. Okay, so that's what is called as an abutment for space maintainer. Okay, hope just Google and see band and loop, you will get an idea of what I just told. Okay, then as a temporary restoration of fractured incisors, fractured incisor means anterior stainless steel crown. I'll just discuss in the next slide. Then in case where there is bruxism or there is this physiological cleansing of the tooth, okay, it can be nocturnal or diurnal. Okay, it can be habitual. It can be due to some kind of this bruxism can be due to some kind of overhanging restorations or high points of the restorations. There are various factors for bruxism. So like in molars are usually affected. It can get worn off. Your molars can get worn off because of bruxism. To prevent that, you can actually put stainless steel crown on the primary molars. To correct single tooth crossbite, you can actually place the crown slightly high. If at all a tooth is indicated for stainless steel crown and there is a single tooth crossbite. Okay, so how you will correct? You will actually place the crown slightly higher, and it is always said that if it is the lower right tooth which is supposed to go, let's say lower right lower back tooth is indicated for stainless steel crown, you can for correcting crossbite, now what you can do, you can use the contralateral side. Okay, contralateral upper side. Okay, that means see lower right quadrant, that is your quadrant 4 is indicated. One tooth in quadrant 4 is indicated for stainless steel crown. So you can select a crown on the second quadrant, that is your upper left. Okay, same tooth, like first primary molar means you select upper first primary molar and place it in the lower second primary molar to correct the single tooth crossbite. Okay, and studies have shown that it is a very effective method to actually correct single tooth crossbite. Again, clinically only this you will understand it much better, but I hope you understood. Like contralateral opposite side crown you can select to correct the single tooth crossbite. So fourth quadrant, if at all you want to put a crown, you select the second quadrant. Okay. Hope you guys understood. Hmm? And for replacing prematurely lost anterior teeth. Okay, so with regard to the anterior stainless steel crown, no, you saw certain indications with regard to anterior tooth. Anterior stainless steel crowns are available, so don't think that you are putting a stainless steel crown in the anterior teeth. Okay, it is with an open facing. So what you will do is, you will place a crown, and if you can look at the second picture, no, in the lingual aspect you can find the lingual aspect is actually the facing of the crown, stainless steel crown. So what we do is we actually fit the crown, then we create a window on the labial aspect. Okay, we create a window. We actually drill holes on all the four sides. Okay, on all the four sides we drill the window, and we remove the labial portion of the stainless steel crown. Then we put a material like flowable composite and do acid etching. Okay, so labially you will get the composite shade, and lingually you will get the stainless steel crown shade. Okay, stainless steel crown will be actually supporting the tooth. Okay, so basically you will fit the crown, then you will remove the labial portion of the anterior stainless steel crown using a burr, and the labially you will cement it with a composite resin. Okay, that's how you do the anterior stainless steel crown. This was the material of choice for restoring the anterior crowns, but later came the advent of much better material like strip crowns. Okay, so that we'll be discussing. Contraindications of stainless steel crown, there is no absolute contraindication, only relative contraindication for anterior teeth, since the lingual aspect. No, actually you can see the silver shade. It is a relative contraindication, not an absolute contraindication. If the tooth is to be exfoliated in a very small period of time, you can decide, like as a clinician, whether you want to give a crown or not. Okay, there is no harm in giving or not giving also. Okay, as a retainer for space maintenance and appliance, as I already told you, like if at all a restoration is required for banding, that's it. No need to actually give a crown to be used as an abutment or a retainer. Inability to fit, if the crown is not fitting, we can actually modify and we can do the fitting of the crown. There are various techniques which you will be learning in your level 12 while placing a crown. But if at all, ideally it is said that you should not manipulate the crown too much. Okay, because it will compromise the strength. So that is also a relative contraindication. But having said that, there are various techniques in which you can actually make the crown fit. Okay, and amount of tooth tissue remaining. If at all there is no sufficient crown remaining, you can do a build up. A core build-up can be done using a JC and give a crown, or like it is a relative contraindication. If at all there is no sufficient crown structure, you can actually even go for extraction also. Okay, so all these are not absolute but relative contraindications. Okay. Now coming to the pedo strip crowns or celluloid crowns. Okay, you can see this material very this is actually what do you say, celluloid material in which actually you place, no, you can see the crown here. You place the composite inside, and like taking an impression, no, you first select the mesodistal dimension, and you select the mesodistal dimension is measured, and you actually select the crown size. Once you select the crown size, no, you place the composite inside the strip crown, and you, like taking an impression, you will place the crown inside the tooth. Okay, and you will actually create something called a vent holes. Okay, you'll, on the labial aspect, you will create one or two vent holes. You can use a probe or what do you say, a burr, to actually create a vent hole. Then once the vent hole is created and you place the composite and you place it inside the tooth, the excess composite is released during the vent hole, and you will remove the excess composite, and you will do the curing. Okay, before that you will do all the steps for composite, like you will do the acid etching, you will apply the bonding agent and all those things. Then you will place the composite in the strip crown. Then, like taking an impression, you will place it inside. The excess composite will flow through the vent hole. You will remove the excess composite. Then you will cure it. Once you cure it, no, that vent hole is created. No, you place a probe inside the vent hole, and you will just strip it off. Okay, you will use the force, and this material is very thin. It will come off just like that. That's why it is called as strip crowns. Okay, you are stripping off the crowns once you cure the composite. Understood, guys? Do you want me to repeat? Okay, okay, you understood. Okay, okay, fine, fine. Okay, so that is strip crowns. Okay, so this is now this actually replaced the anterior stainless steel crown, because anterior stainless steel crown requires lot of preparation, whereas your pedo strip crowns is very easy. Okay, so and more aesthetic also. Okay, so, and finally, we have the polycarbonate crowns, which is nothing but your, it is an acrylic material. Okay, it is an acrylic shell, which was actually there just along with your just before your anterior stainless steel crown. Polycarbonate crowns were the crowns for choice. Okay, since it's an acrylic material, no, you will actually cement it using a heat cure acrylic only. Okay, so but the problem is again, no, it had severe contraindication, and the strength was also not great. Okay, so you will use the acrylic only to actually self cure acrylic only to actually the cement this crown. Okay, so that is one variation. You don't use any JC or anything like that. You will use the acrylic only to cement this crown. And indication, it was indicated for just like the other indications: grossly caries anterior teeth and failure of other restorative materials. Okay, but it had problems with strength. That's why it was contraindicated in severe bruxism cases. When there is severe physiological cleansing, the strength of this crown was not adequate to actually withstand the occlusion forces. And when there is deep bite, again, there is excessive masticatory forces being directed towards this crown, and when there is excessive abrasion. So this slide is very important. Okay, the contraindications of polycarbonate crowns you're supposed to know. Mostly you'll get an MCQ from this slide. So know this contraindication of the polycarbonate crowns. So because of these drawbacks, no, polycarbonate crowns are not used anymore. Okay, we are sticking to strip crowns, and nowadays we have something called as new smile crowns, which is the latest. Okay, which is not there, which is not available in our college also, and which is the newer material. New smile crowns are the zirconia based pediatric dentistry crowns. Okay, so zirconia is a very costly material, and all the preparation should be done on the tooth rather than the crown, because you cannot do any kind of manipulation on zirconia, right? It is a very hard material. So new smile crowns are the latest crowns for pediatric dentistry, especially for the anterior region. Okay, and even in the posterior region, it gives good aesthetics when compared to your stainless steel crowns. So these are the different materials or restorative materials which we are actually using right now. Okay, so any doubts regarding any slide which you want me to repeat? Hope everything is clear. Anything which you